And I'd like to thank you for the opportunity to share with you our experience over the past 4 years with the Felix project, which is using AI for the earlier detection of pancreatic cancer. One of the things to remember with pancreatic cancer, the survival, even after many years of improvements, is in the 7 to 8% range at 5 years. What's important to remember, however, is that in retrospect, up to about 2/3 of cases can be detected on a CT scan where initially it was read as negative. Often these tumors are small. Often it may be a dilated pancreatic duct but no mass, but they are in retrospect detectable. When you think about that, there's no great surprise that we still have errors. When you look at the 40 years of CT, initially we had 30 to 40 slices per study, limited resolution, we put things on film. Within a decade, we had studies up to 100 slices. Scan times had improved. Scans which were taking 10 seconds now took 5 seconds. But again, resolution was still challenging. Fast forward 30 more years, and now there is no film. Everything, of course, is digital. An average case is 2,000 to 4,000 scans, where 0.75 millimeter thick sections every 0.5 millimeters is standard, and a study of the abdomen takes in under 10 seconds. There's no motion, there's no blurring, and we have high resolution images. Yet still the error rate, depending on the article you read, when studies have positive findings, the error rate still can average as high as 30%. And so there needs to be some way of improving those numbers. Now, the way to think about this from a clinical perspective, and I'm a radiologist, we've always had axial CTs, and then we added coronals and sagittals, so-called multiplanar. We then added 3D imaging, and the most recent 3D imaging is a form of volume rendering called cinematic rendering. But at the end of the day, the need for augmented reality, but especially AI and deep learning, including radiomics, may be the way of changing the paradigm in terms of lesion detection. So can we detect pancreatic cancer earlier? That is, can we pick it up at a time where surgical intervention will likely lead to a cure of that patient? And I think our experience is that the answer would be yes. Now, we've looked at things like texture mapping. This is cinematic rendering, a really good look at the normal pancreatic gland you can see here, and the arteries, the SMA, the hepatic artery. We can see the texture of the spleen, the texture of the pancreas, the kidneys. And by looking at texture, one of the things we recognize is that we can pick up more subtle tumors. So for example, in this patient, when you look at the initial scan, this was read as negative. But one would imagine, is there something going on here? Unfortunately, a few months later, the patient still had symptoms and now has multiple liver lesions. The tumor is large and the tumor is unresectable. Now, if things were detected at the first study, the patient potentially would have been resectable. So can we change the paradigm? And again, here's just 2 images. Looking hard at this image, do you see a mass here? Well, maybe there's some subtle textural change. But this was read as negative, and again, of course, when it's finally read as positive, it's just a little bit too late for that patient. Now, on the texture mapping, you can see early there are minimal textural changes here. The texture of this portion of the gland, which eventually was documented as the tumor, looks different than the other parts of the gland here and here in the head and in the tail. That's the patient's tumor. Now, of course, as the tumor progressed, it became more necrotic, and so it's much more obvious, but you could see the lesion was there and potentially could have been detected. Now, the role of AI was our thought, and the Lustgarten Foundation has supported us now in our 5th year. What we were able to do is have 5 people literally be able to segment by hand using Velocity software on Varian systems to be able to isolate the individual organs, the individual vessels, and eventually isolate tumors. Our processing was done with DGX-1 NVIDIA computers, and it was a combined effort between the School of Medicine and the engineering school at Hopkins, in the medical side, Bert Vogelstein, Ken Kinsler, Ralph Rubin from pathology. On the computer side, Alan Yulee and his group at Homewood, and myself and my colleagues within radiology. The first thing we did on normal studies, and everything we've done in this entire project needed documented normal or abnormal studies. We used renal donor patients who were at least 5 years out, were negative studies, and patients had no evidence of disease later, and we taught the computer to recognize the various organs. Now, to do this, we not only outlined the pancreas, but the stomach, the liver, the individual vessels, roughly 25 different structures, which you can see here on this 3D image. And then what we did was teach the computer to recognize this, and within a year or so, we were able to have our deep network prediction of the various organs and vessels equal to that of manual segmentation. And you can see just a simple example here is the pancreas, CT scan. Here's our annotation, and that's the prediction by the computer. We then went to try to teach the computer to recognize pancreatic cancers. We showed it a range of tumors, different locations, different sizes, different densities, different textures, and have used well over 2,000 pathologically proven cases of pancreatic adenocarcinoma with dual-phase datasets in arterial and venous phase imaging. To analyze the data, we developed different algorithms, a course-defined pancreatic detection algorithm, which you can see in this example. We also developed ways of looking at the shape of the gland, which becomes particularly important for lesions off the lower uncinate process or the tail of the pancreas. We developed recurrent saliency transformation network, which allowed coarse and fine segmentation networks to work together, and again allowed us to segment these data sets efficiently and correctly. And just for some examples, here's a patient with a pancreatic mass, dilated pancreatic duct. Here's the deep network prediction. The red is the patient's tumor, and you can see very nicely the accuracy of the deep network predicting the tumor, showing in purple the patient's gland, and in green the dilated pancreatic duct. So very good accuracy, not only detecting of the tumor, but being able to define its margins. We then looked at random forest classification with radiomics features, and again using this idea from the segmentation to be able to use radiomics to be able to detect normal or abnormal glands, looked at it for being able to, through a range of filters and with random forests, training it to be able to separate between pancreatic adenocarcinoma, pancreatic neuroendocrine tumors, as well as normal. We also trained it to look at some mimics of pancreatic cancer, including autoimmune pancreatitis. And with that, we were very successful in being able to be accurate on all three fronts. When you look at our data sets, our overall accuracy was 94% or greater, minimal number of false positive in patients with a normal gland, and high accuracy for detecting the presence of pancreatic adenocarcinoma or neuroendocrine tumors, which can be a mimic. Again, for us, it became very important to detect all pancreatic lesions, because if we want to use this in clinical practice, radiologists are going to expect that you're able to pick up all tumors, ranging from cysts to neuroendocrine tumors to adenocarcinoma. When you look at some examples, we then focused on developing algorithms that allow detection of smaller tumors. Here's a tumor 1.5 centimeters in size, the tumor's in red, and here's the deep network prediction, basically a one-to-one comparison. Another example of a small tumor. Here's a patient with a dilated pancreatic duct. There's the tumor, again, 1.4 centimeters, and here's the deep network prediction. So again, very accurate, not only depicting up a tumor, but defining borders in a one-to-one correlation. And here's another example, again, dilated duct. There you can see the tumor, 1.2 centimeters, one of our smaller tumors, and the deep network prediction. It's very hard to get good data sets with small tumors. We used cysts as well as a surrogate and can detect lesions 4 millimeters or better. We also trained the computer very much like you would train a radiologist. You want to be able to look at the pancreatic duct. When you have cutoff of the duct, there invariably is a tumor present. So we developed algorithms to define the pancreatic duct and developing algorithms for the common duct as well. Just a very nice example showing you the dilated duct, and where the duct is cut off, there's the patient's tumor. So in cases with isodense tumor, the ability to show where the tumor should be will be very helpful to the radiologist in reaching the right diagnosis and being able to biopsy the patient at that time. We also put a lot of effort into radiomics, which is the high throughput extraction and analysis of quantitative features from medical images. We were able to use extraction of quantifiable imaging markers based on tumor signal, intensity, shape, and texture, and then applying these imaging markers for the disease diagnosis and eventually for prognosis. We talk about radiomics as first order, shape, and second order and higher order statistical outputs. With first order statistics, distribution of values of individual voxels, histogram-based methods, mean, median, maximum, minimum, uniformity, entropy, skewness, and kurtosis. Literally, we looked at nearly 500 different features, looking and trying to figure out which features were most important, imposing filter grids and wavelengths and various Laplacian and Gaussian filters to be able to look at image borders, smooth the image, and be able to define changes within the pancreas representing tumor. We previously published our results using CT radiomics features for differentiating pancreatic adenocarcinoma from normal pancreatic tissue, and we found that we were able to do this with over 98% accuracy. Again, one of the key things we spoke about was the ability to use this then to pick up smaller tumors when the scans are negative. As I mentioned at the start of this talk, there is now a general feeling that pancreatic cancer may be present 2 to 3 years before it's detected, and then if we could only pick up things earlier, it would change the outcome of patients. Now, in terms of the overall process in radiomics for pancreatic cancer, you can see some of the information here, looking at shape, first order statistics, texture, various filters, creating a signature or a fingerprint for the various appearances of pancreatic adenocarcinoma. So it became very clear as they were able to predict the presence of tumor and separate tumor from normal patients or patients with diseases that simulate cancer like autoimmune pancreatitis, and do this anywhere between 15 and 25% better than a radiologist. We extracted 478 radiomics features in this study. Again, you can see very nicely that the appearance of PDAC, pancreatic adenocarcinoma, has a different signature than normal controls. When you looked at the various features, again, look at the overall accuracy, 99%, sensitivity, 100%, and specificity over 98%. And this has been proven true in all of our studies. If you go down from nearly 500 features to 40 features or even to 5 features, looking at the top 5 maximally relevant features, you are still able to get into the mid-90s. Now again, with processing and doing this efficiently, we should be able to use the maximum number of features and still get the right diagnosis with the highest of accuracies. And again, the results by Dr. Chu, our results show that after manual segmentation of pancreas boundaries, radiomics features in the random classifier were highly accurate in differentiating adenocarcinoma from normal studies. And again, the features most relevant were shape and textural heterogeneity. Now, a key thing then is being able to combine the deep learning and radiomics. When you think about it, perhaps the way to think about it is you now have two systems looking for the same findings. Perhaps the radiomics would be the one to say normal versus abnormal, and then the deep learning will be showing you where the tumor is. But combining the two from both arterial and venous phase imaging, whether you run them individually or have deformable registration, again, pancreas segmentation becomes critical. And of course, the deep learning can be used for the segmentation of the gland, and then going into combining them and then being able to use tumor localization, and then perhaps visualization using things like cinematic rendering. So again, the goal is not to have different patterns or different pathways, but to have a single pathway. And combining deep learning and radiomics would seem to be an ideal structure. And you can see it shown in this as well. Thinking about how the user, the radiologist, would use it, they just simply would input the data files. The processing would occur, both the cinematic rendering for visualization, the potential workflow looking at the deep networks, and looking at radiomics to be able to produce an outcome to suggest to the radiologist precisely where the tumor is and potentially what type of tumor it in fact is. One of the things we're also looking at is not only being able to predict the presence of tumor, but being able to predict the outcome of the patient's tumor. So, for example, can we predict what patients will locally recur? Can we predict what patients will get liver metastasis early, although their tumors don't seem to be that aggressive and are resectable? We're also looking perhaps at ways of improving and choosing which chemotherapy can be used for individual patients. The whole idea about using AI for precision medicine, precision imaging, becomes very critical. So there's no doubt that the current status of radiologists, even in the best centers, doing CT for early detection of pancreatic cancer has not been successful. Again, potentially we're missing a half to 2/3 of cases when they could potentially be resectable. AI is needed to be able to change this paradigm. Radiologists need help from AI to improve their accuracy. And our goal in the Felix project was to build the system for early detection of tumors when patients can be treated correctly. And I do want to thank the Lustgarten Foundation for their support, and without their support, this project would not be possible. And we are committed as we enter our 5th year to be able to change the paradigm of pancreatic cancer by doing early detection, allowing for earlier therapy and better outcomes for our patients. And with that, I thank you very much for your attention.